Narendra Reddy University Hospitals of Leicester. Pituitary apoplexy. Narendra Reddy University Hospitals of Leicester. East Midlands Pituitary Day, Nottingham, May 12, 2016. Outline definition of apoplexy, etiology and presentation. UK Guidelines 2011. Pituitary apoplexy audit. Pituitary apoplexy, PA. King Henry IV Part 2. Derived from Greek word apoplexia, striking away. To be struck down utterly by gods. Pierce Bailey first described 1898. Imbruim coined the term J. neurosurge 1950. Apoplexy has been used as a plot device throughout literary history. It is referred to as apoplexy in Chaucer's Nun's Priest's Tale, from the Canterbury Tales, and it is referred to as apoplexy in Shakespeare's Henry IV, Part 2. Because so many deaths remained sudden-seeming and unexplainable before the evolution and refinement of medical science, apoplexy was a common explanation. Definition: classical apoplexy, subclinical apoplexy. Sudden onset and severe headache, vomiting, visual impairment, ophthalmoplegia and altered consciousness. Clinical syndrome 2 to 7%. Radiological or histopathological diagnosis of an asymptomatic pituitary hemorrhage or infarction. Investigational finding 7 to 15%. Waghai et al., J. Neurosurge 1981, Bonecki et al., Acta Neurochirurgica 1993. Medical emergency, overall mortality 1.6%, frail patients -1.9%. Male preponderance : 1.5 to 1. 5th and 6th decade. Pituitary infarction or SH. Pathophysiology. Normal intracellular pressure, ISP, 7 to 15 mm Hg. ISP greater than 37 mm Hg equals compression of pit vessels at diaphragmatic notch. Intratumoral vasculopathy. Intratumoral VEGF and TNF-alpha levels. Microadenomas and even in normal pituitaries mechanisms unknown. Sheehan's postpartum hemorrhage. Rapid growth of tumor outstrips blood supply, producing ischemic necrosis hemorrhage. Interruption and compression of the portal vessels and pituitary stalk by the slowly growing pituitary adenoma. Zaire et al., J. of Glen Endometab, 2004. 60% of cases occur spontaneously. Hypertension most common. Kapatna C., John A. H. Wass, Year J. Endo 2015. Victorian Health and Medicine. A person is warned of the approach of apoplexy by various symptoms. But most frequently he falls to the ground without any warning, and lies as though in a deep sleep. Apoplexy - from the Dictionary of Daily Wants 1858-59. Headache virtually 100% of cases. Urgent medical attention sought. Randeva et al., Clen Endo 1997, C. Kapatna, John A. H. Wass, Year J. Endo 2015. Mimics neurological emergencies. Subarachnoid hemorrhage. Bacterial meningitis. Ophthalmoplegic migraine. Suprasellar aneurysm. Stroke. Hypertensive encephalopathy. Cavernous sinus thrombosis. Hypocortisolemia greater than 70% cases, an important cause of mortality. Where a person is seized as described, a medical man should be sent for. UK Guidelines Algorithm for the Management of Pituitary Apoplexy. Modified from Rajaskran et al. Clen Endo 2010. Sudden onset severe headache. Nausea and/or vomiting. Visual impairment. Altered consciousness. Suspect pituitary apoplexy. Hemodynamics. Pituitary profile. Steroids. MRI. Visual evaluation. PIT-MDT. Surgery versus conservative. Ensure hemodynamic stability. Management of fluid/electrolyte balance. Consider hydrocortisone replacement. Urgent biochemical and hormonal evaluation preferably prior to steroid administration. FBC, U&E, LFT, clotting profile, IGF-1, GH, PRL, TSH, T4, LH, FSH, random cortisol, testosterone or estradiol. Urgent MRI to confirm diagnosis or dedicated pituitary CT scan if MRI contraindicated. Liaise with regional endocrine and neurosurgical team following confirmation of diagnosis. Severely reduced visual acuity. Severe and persistent visual field defects. Deteriorating level of consciousness. No. Yes. Consider surgical management. Conservative management. Close monitoring of neurological, visual and endocrine status. Patient stable or improving. Yes. No. Continue conservative management. Consider surgical management. Endocrine evaluation and hormone replacement if appropriate. Follow-up monitoring of neurological, visual and endocrine status. Radiological surveillance for recurrence of pituitary tumor. Post-operative endocrine evaluation and hormone replacement if appropriate. Follow-up monitoring of neurological, visual and endocrine status. Radiological surveillance for recurrence of pituitary tumor. Clinical assessment to be suspected in pre-existing pituitary tumors. During dynamic stimulation tests. Anticoagulation treatment. Major surgery e.g., CABG etc., assessment, CAND. Lower prolactin equals higher cellular pressure equals higher hypopituitarism. Hyponatremia equals hypocortisolemia plus excessive ADH release. Zaire et al., J. of Clinendo Metab, 2004. Randeva et al., Clinendo, 1997. Stabilization equals fluids plus steroids. Hydrocortisone 200 mg for stat. Hydrocortisone 100 mg MQDS. Or 2 to 4 mg per hour for infusion. Tapered to oral 20 to 30 mg/day. Dexamethasone not preferred. In neurosurgical HDU. Visual assessment within 24 hours, imaging CT better in hyperacute stage hypertense. Detects tumor in 80%, 21 to 28%. MRI hyper/ISO intense on T1. Hypointense on T2 weighted. Hyperintense in T1 and T2 after 7 days. Heterogeneous after 2 weeks. Detects tumor in 100%, Gen 88%. Semple et al., J. Neurosurg 2008. Guideline Principal Controversy Surgery Conservative. Absent or mild neuroophthalmic deficits. Regular neuroobs. Daily visual assessments. Electrolytes monitoring. Regular endocrine evaluation. Severely reduced VA or VF. Progressive deterioration of VA or VF. Deteriorating GCS. Principal controversy, surgery versus conservative. Early SX better visual and endocrine outcomes. No difference. Randeva et al., Clinendo, 1997 N equals 35. Bills et al., Neurosurg 1993 N equals 36. Sybil et al., Pituitary 2004 N equals 45. Ayuk et al., Clinendo 2004 N equals 33. Gruber et al., British J. Neurosurg, 2006 N equals 30. Conservative Rx. 3 out of 6 patients treated conservatively died at 4 to 14 days of diagnosis. Damoda L.A. et al., J. Neurolog Sciences 1999. Surgery versus conservative. Controversial, role and timing of SX. Paucity of RCT studies, rarity of PA. SFE guidelines. Pituitary MDT. Patient included in decision. Information leaflet. The role of acute neurosurgical intervention remains a key controversy in the management of pituitary apoplexy. The rarity of condition renders it difficult to undertake randomized controlled trials, and the evidence for definitive management is derived largely from retrospective case series. No clear criteria to define a significant neuroophthalmic deficit. Pituitary apoplexy score, PAS. Variable. Pituitary apoplexy score. Level of consciousness. GCS 15. GCS less than 8 to 14. 2. GCS less than 8. 4. Visual acuity. Normal 6/6. Unilateral. 1. Bilateral. Visual field defect. Normal. Ocular paresis. Absent. During their development, the guideline group recognized that there are no clear criteria that define a significant neuroophthalmic deficit in pituitary apoplexy. There was a need for objective clinical evaluation in a cohort of patients to allow risk stratification and a monitoring tool for patients presenting with suspected pituitary apoplexy for the purposes of audit and randomized clinical trials. Retrospective PA validation. Oxford and University College Hospital, London. N equals 54. 1979 to 2009. Internally reviewed by 6 clinicians. Influence of PA on SX versus cons. Unresolved PA. Prospective Audit SFE Restricted Grant 2013. Nationwide Prospective Audit. Greater than 10 centers. Wildrake et al. Pre- and 3 months post-surgery evaluation. Prognosis mortality 1.6% minus 1.9%. 80% of ocular deficits resolve at end of 1 year. Total resolution of paresis and visual acuity, field defect persists 20 to 30%. Long-term hormone deficits common 60 to 80%. Relapse of PA is rare, recurrence of tumor is common. Summary: pituitary apoplexy is a medical emergency potentially fatal. Hemodynamic stabilization and steroids. MRI, endo, ophthal assessments. Early PIT MDT panel members.